Hi, my name is Claire, and this will be my presentation for Lifespan Health Assessment of a normal GI assessment while also discussing abnormal findings for constipation. The assessment begins with an introduction of myself and criteria for the patient, as well as a confirmation of their chief complaint or reason for visit. During this time, I will explain to the patient what the appointment will look like and what they can expect throughout the appointment. Past medical history includes any gastrointestinal disorders, ulcers, polyps, IBS, or inflammatory bowel disorders, cirrhosis or hepatitis of the liver, abdominal injuries, history of UTIs, major illnesses such as cancer, kidney, or cardiovascular disease, sexually transmitted infections. Has the patient been taking steroids or NSAIDs or aspirin, any medications that would cause abdominal side effects? Family history includes things like colorectal cancer, gallbladder disease, kidney disease, malabsorption, like celiac disease. Personal and social history. What forms of food does the patient typically eat? What is their diet like? Are there food intolerances or restrictions? Any recent weight changes? Does the patient drink alcohol? And what does that look like for them? Do they use tobacco or illicit drugs? Have there been any recent or chronic stressors? Any infectious disease or trauma? If it is a female patient, asking about their last menstrual cycle or their menses. While these are generalized questions and forms of personal and social history, there are more areas to inquire depending on the population, such as infants, children, pregnant people, or elderly patients. To establish information on the present illness or chief complaint, um, with the patient, you should assess for any recent GI, GU, or gynecological changes, any medication or supplements that could affect the GI system, or causative factors. This information can be used to help assess and determine any further investigation or possible abnormalities that could be found within the assessment. The mnemonic old cards can be used to assess characteristics of the problem and ensure a comprehensive assessment. O for onset, when the problem first started, what the circumstances or setting was, when it occurred, and the manner it occurred in. Location, where the exact location it occurred, was it localized or generalized? Duration, the length of the episode, does it occur constantly or intermittently? Character, those descriptive words like stabbing, burning, or dull. Aggravating or associated factors like food, certain movements, activity, or rest. Relieving factors, what relieves the pain or the episode. Temporal factors, the frequency of occurrences, the typical description of the episode, or change of intensity, if things are generally getting improving or worsening, and the severity of the symptoms, rating on a scale of 0 to 10, and how it affects their daily life. The exam starts with a well-lit room, offering a chaperone when appropriate for the patient, explaining the exam and creating communication with the patient. And if they inquire, have any questions, it's best to perform this exam with an empty bladder. A full bladder can interfere with the accuracy of the abdominal exam as well as make it uncomfortable for the patient. The patient should be lying in a supine position with their arms at their side. To help make the patient comfortable, place a pillow under their head or under slightly flexed knees. Drape a sheet over the patient's chest or abdomen, but uncover the abdomen when assessing to ensure it does not interfere with the assessment. The drape can provide warmth and privacy for the patient. If the patient notes any tenderness or tender spots, examine those last. Help keep the patient comfortable and relaxed. Allow them to ask questions and help create a conversation and explain while assessing them. Create a slow and gentle approach. The abdominal exam consists of four portions: inspection, auscultation, percussion, and palpation. The abdomen can commonly be divided into quadrants or regions when examined. I've attached the images so you can see both variations, either the 4 quadrants or the regions, and some of the anatomy within that. Beginning the inspection, being at the patient's side allows for the provider to see any shadows, skin variations, colors, or characteristics. A fine venous network may be noted as well at this time. Take time to note any color changes, bruises, redness, lesions, or nodules. Inspecting the contour of the abdomen, is it symmetrical? The umbilicus should be noted centrally and without displacement, free of redness or inflammation. You can move to a standing position near the patient's head, noting any distension or bulges. If distension is present, note if it's symmetrical and the location. Having the patient lift their head from the exam bed will contract the abdominal muscles, making it possible for a hernia to protrude or to examine the separation of the rectus abdominal muscles. With the patient's head resting back on the table, movement can be observed. Smooth, even movement should occur with breathing. Some unexpected things that could be found include jaundice or cyanosis within color, ascites, Sister Mary Joseph's nodule or Cullen sign. Auscultation occurs prior to percussion or palpation to ensure that the bowel sounds do not change throughout the assessment. Place the diaphragm of the stethoscope on the patient's abdomen, ensuring that the stethoscope is warm. Listening to bowel sounds, noting their character and frequency. Some variations may be long, prolonged gurgles, increased bowel sounds, high pitched tinkling, decreased sounds, or absent sounds. Absent sounds do require listening for 5 continuous minutes, and typical bowel sounds can be heard anywhere from 5 to 35 minutes. Listening with the diaphragm to note friction rubs over the liver or spleen. These can be heard with high pitched and with respirations. A bruit sound is a harsh or musical intermittent sound. Finish by using the bell of the stethoscope at the epigastric region and the arteries. Vascular sounds are well localized. Auscultating with the bell at the epigastric region and the umbilicus for the venous hum, which is a low, soft, and continuous noise. Percussion is used to assess the size, density of the abdominal organs and can be used to detect fluid, air, and masses. There's different notes that are tympany, hyperresonance, resonance, and dullness. Start by percussing in all 4 quadrants of the abdomen to sense overall tympany and dullness. Starting with the liver span percussion, beginning in an area of tympany and working towards an area of dullness. The area of dullness is often heard by the costal margin or slightly below, noting the placement. The usual span of the liver is 6 to 12 centimeters, and the percussion allows an estimate of the liver size. Percussing the spleen posterior to mid-axillary line on the left side. A small area of splenic dullness may be noted about the 6th or 9th rib. Gastric air bubble percussion occurs at the left lower anterior rib cage and left epigastric region. It is a lower pitch than the tympany of the intestine. Kidneys are assessed for tenderness. You could do this by assisting the patient to a sitting position, using the palm of the hand struck by the fist of the other hand to the costal vertebral angle. This is often performed while assessing the patient's back. Palpation allows the provider to assess organ size, shape, mobility, and consistency, working from light palpation and progressing towards moderate or deep palpation. Light palpation occurs by laying the palm of the hand lightly on the abdomen with fingers extended and held together. Depress the abdominal wall no more than 1 centimeter using light and even pressing circular motions. Light palpation can be used to help identify muscular resistance and any tenderness. If resistance is noted, you should also note if it is voluntary or involuntary. Moderate palpation is done using the same technique as light palpation. However, you do exert more pressure. You could also use the side of your hand in this maneuver, and it can help assess organs that move with respiration. As the patient inhales, the organ can be displaced downward, and you can feel the bumps gently against your hand. Deep palpation is used to detect less obvious masses in the abdomen. This is done by using the palmar surface of the extended fingers, pressing deeply and evenly into the abdominal wall. The provider is able to feel borders of the rectus abdominis muscles, the aorta, and portions of the colon. If bimanual palpation can also be used if there are any difficulties with palpating. When masses are identified, note the location, size, shape, consistency, tenderness, mobility, and movement with respiration. Masses in the abdominal wall will continue to be palpable if the patient tilts their head off the bed. And organs to assess with palpation include the liver, gallbladder, spleen, kidneys, and aorta. Most often, the liver is not palpable. A healthy gallbladder is also not palpable. The spleen may be felt if it is enlarged, and the right kidney is more commonly palpable in comparison to the left kidney. Following the exam is a portion of time where you can ask the patient questions, interpret and summarize any findings, ask the patient to summarize their understanding of any findings, repeat findings and instructions for the patient, and explain what the next steps are for them, whether it's appointments or when to reach back out. With the abnormality or chief complaint of constipation, some things that could be noted is a fecal mass may be felt with palpation, noting that it could be soft, rounded, boggy mass within the colon. Stool noted in the rectum, decreased bowel sounds, and pain characteristics that might be colicky, dull, or steady pain that does not progress or worsen. For history of the presenting illness with constipation, some of the character noted might be abdominal pain or discomfort, blood in the stool, diarrhea, or bloating or gassiness. Some pattern is to note is the last bowel movement. Was there pain with it? Is there a change or size and consistency of stool? What's the patient's diet look like? Is it a high fiber food or how much fiber are they taking? What's their fluid intake? And if they've had any recent diet changes? Noting medications that the patient could be taking, any laxatives, stool softeners, iron, diuretics, or opioid medication. And then what is the patient's lifestyle? Is it sedentary or what does mobility look like for that individual patient? These are the references used throughout this presentation, and thank you.